IP एड्रेस, जस्ट नाम बदल बदल के. ओके, नो वरीज. Now today we'll be starting with this. Just keep the chat box. Yeah. Yes, yes, I ignored, but still I was like bit curious that from which city are these mails coming. So that's why I traced it back. Otherwise, I usually ignore such emails. I don't even read them fully. But I mean, सब्जेक्ट में ही बोल्ड लेटर्स में ऐसी ऐसा लिखा था ना, क्या बताए. ये सभी चीज. नहीं नहीं नहीं, आई वोंट डिस्क्लोज एनीथिंग लाइक दैट, क्योंकि वो क्या होगा, वो अननेसेसरी. मतलब इफ आई एम हर्ट तो देन व्हाई व्हाई शुड आई हर्ट यू. नहीं, वो तो ये तो जस्ट मैंने अपनी क्यूरियोसिटी के लिए, आई नॉर्मली आई डोंट इवन डू दिस. बट मतलब वो एक मेल आई तब तक कुछ नहीं, दो तीन. बट इन द इवनिंग व्हेन आई सॉ दैट सो मेनी, तो देन आई वाज लाइक, लेट मी सी. So it is like you can open the header, and from the header, that is what is called as the TCP/IP, and from TCP/IP you can really backtrack it. ठीक है यार, they don't deserve the cover, that's okay. Uh, wait. Yeah, Abhijit, I mailed you, but you didn't reply. It's my second class. What should I? तो गलती हुई. अभिजीत, शायद आपकी मेल ना इस चक्कर में मिस हो गई है. इंसानिया, हाँ, इग्नोर टॉक्सिक पीपल, यस सही बात है. आर दीज ईमेल्स फ्रॉम दिस बैच? यस यस, इसी बैच में से है, इसी बैच में से है. दो ईमेल बाहर की थी. बाहर की मतलब मेडिको ही, बट सीनियर. दो ईमेल तो मतलब बस उसी बात पे थी. इट वाज ऑन जेंजी. आई मीन दैट वाज माय व्यू. देयर शुड नॉट बी एनीथिंग लाइक, मतलब ये क्या जनरेशन ये और जनरेशन वो. बट दे सेड नो, वी आर मच मोर एडवांस देन योर जनरेशन. रिप्लाई नहीं किया, ठीक है. इग्नोर स्पर्श, दे आर जस्ट टू चेक योर रिएक्शन. हाँ, ठीक है, सही बात है. यार राइट. एआई क्लासेस, अरे दोस्त, एआई क्लासेस क्या, मतलब मैंने तो इतनी बड़ी लिस्ट बना के रखी है. आर दीज ऑनलाइन लेक्चर्स अवेलेबल टू? अच्छा, अभिजीत ना, अभिजीत, यू अलॉन्ग विद दोस्त हु ज्वाइन फॉर द फर्स्ट टाइम, या जिनके अभी मतलब फर्स्ट सेकंड या थर्ड क्लास ही है, राइट, थर्ड फोर्थ क्लास, बस उतना उतना ही आपने पढ़ा है. आई जस्ट सी टू दैट. पता नहीं क्यों आपका मेल मिस हुआ. बट say all these lectures, they are on my YouTube channel, right, in the same order. right? Name is also same, Dr. Bankim Jani. And you just go to playlist. Important it that don't try to search for separate lectures. Go to playlist. In playlist, there would be upper limb or upper limb में all the lectures from 1 to 12. Start watching these lectures in this order only. Don't मतलब randomly मत देखो. फिर वो प्रॉब्लम होगी. मतलब you won't be able to get the contacts very easily, right? And one more thing which you are supposed to do, and that is the general anatomy. And there will be another playlist that is general anatomy. Do watch all these lectures also. बाकी इतना एंड आपने मेल भेजा होगा तो नो नीड टू सेंड अगेन या जस्ट सेंड इट अगेन सो दैट आई कैन शेयर यू द गूगल ड्राइव लिंक. ठीक है. I'll share you the Google Drive link in which all the PDFs, whatsoever we have discussed till this point, they are already there. Plus, there is some other material. Hmm. I am not unhappy. नहीं. ये क्या पिछले 2 दिन में ये हेट डोज जरा ज्यादा ही बढ़ गया था. Hmm. I mean, the persons, they are so free that they can write 3 pages of that such mail. 3 पेज भर के. मतलब कैपेसिटी चाहिए. एंड सब था उसमें कि इतना पढ़ने की क्या जरूरत. क्लिनिक्स कोई पूछता नहीं है. एंड अपर लिम की देर इज नो इम्पोर्टेंस. वो बस 2-4 सवाल आते हैं वगैरह वगैरह. चलो आई एग्री टू मतलब दैट जेंटलमैन दैट इन यूएसएम about the anatomy of upper limb you will hardly get in the entire USMLE exam. Step 1, you'll get 2-3 questions of upper limb. 2-3 questions. Totally agree. मतलब से एब्डोमेन एंड हेड एंड नेक दे आर स्लाइटली मोर इम्पोर्टेंट बट उसके भी आप गिन के मतलब 4-5 क्वेश्चन गिन लो. दैट मीन्स कि आपने जो इतना सारा पढ़ा तो इसमें से मुश्किल से 2 क्वेश्चन. 2 questions इन यूएसएमएलए. बट द पॉइंट इज इट इज नॉट अबाउट द क्वेश्चन. अभी हम यूएसएमएलए की तैयारी नहीं कर रहे. वी आर मेकिंग अवर बेस बिकॉज ऑन दिस बेसिस देयर विल बी द on this basis there'll be so many things. हाँ, radiology आएगा. Right? In radiology, they'll be showing that scaphoid fracture that you have to diagnose. So that's the thing. बस वही तो है. मतलब जब जब नॉर्मल ही नहीं पता तो फिर you'll find so much difficulty into the abnormalities. Right? So that was the reason to study this anatomy. मतलब एग्जाम के लिए ठीक है. मतलब आई एग्री टू हिम दैट एग्जाम में तो 2-3 क्वेश्चन ही पूछते हैं. सही बात है. Chalo, let's start with our today's topic, and this is implementing clinically. Whatsoever we have discussed till this point of time, there would be some sort of revision also along with it. Plus, I have added something extra. So let's start implementing clinically. So in upper limb, we will use the word pre-axial and the post-axial. Axis concept, which axis? The axis which is passing through the center of the upper limb. Right, center of the upper limb. So when we talk about the radial side is the outer side, right? Radial side is the lateral side, right? So this is the lateral side. So it is called as जैसे बाहर से कुछ चीज आ रही है. So it is before axis and other side is called as the post axis, right? Pre-axial and the post axial. Importance कुछ नहीं, zero. But when it will come to surgery, very much important because that is where you'll be said that some of the planes, they are less vascular, some of the planes, they are more vascular because whenever we'll be doing the surgery, you would like that person should bleed minimal, right? Bloodless surgery, आपने नाम सुना होगा, bloodless surgery. So this is where its importance will come up. कि जब आपको बोलेंगे को will be starting with the preaxial plane. Right? तो तब नहीं होना चाहिए अरे preaxial plane क्या है? But simply it is the radial side. We'll be starting from the radial side and then we'll proceed with the surgery towards the post axial, that is towards the ulnar side. Okay, simple. Then, so yes, in preaxial, that is where it is, where the radius bone is there. There would be radial artery. There would be cephalic vein, right? So that is there. And on ulnar side, there is ulna is the bone, ulnar artery, basilic vein. So these are the veins. Just to remember the name of the veins. Right? Upper limb, flexor or anterior, that you know. As limb rotate, ye jara interesting. This is embryology. This is embryology, right? And in embryology, these are called as the limb buds. Limb buds. So when the body is formed and then limbs they come out, upper limb comes out, lower limbs come out, right? So it's a char nikle. But then what really happens is upper limb buds, they rotate out and the lower limb buds, they rotate in, right? So this is the direction. So these are the upper limbs, they rotate out and the lower limbs, they rotate in. That's the reason that in upper limb, flexors are anterior, correct? Flexors are anterior. As limb rotates laterally, that is in to out, so that flexors, they have come forward. Reverse in case of lower limb. Hard in anatomical position, we do flexion like this. Palm flexion jab karte hain, to that is where,
Posterior.
yes, posterior, right? That is posterior. So that's the difference. This difference is again, when you, those who have started, say, lower limb lectures from the YouTube, right? They must have realized, yes, this is the only difference that we have to understand, that how the nerves, because see, when the muscles, they are going back, even the nerves will also be following them, right? So that's how the whole system works. But this is, if you remember this much, understanding of lower limb would be very easy. On to the clavicular fracture. This is what is called as the fall on outstretched hand, right? It is also called as the foosh, right? That's a ajib se short abbreviations, but well, still it is called as, because foosh importance, clavicular fracture to शुरुआत है, right? उसके बाद it can go to supracondylar fracture, it can go to scaphoid fracture, right? So all those fractures which can occur when the person falls on the outstretched hand, हाथ ऐसे और गिरे. So because the entire pressure is transmitted from one point to another point, and there can be multiple fractures also, right? If the bone density is less, so there can be multiple fractures. And so that scaphoid can also go, clavicle can also go, all those things, they can occur together. But this is one of the very common question, fall on outstretched hand. आपके हाथ में clavicle दिया, तो definitely this question would be asked. This you have to remember, junction, that is medial 2/3 and lateral 1/3. For all those friends, those who have joined late, late means जिनके अभी दूसरी, second या third lecture ही है, so for them, the clavicle which is present over here, right? So this is the midline. This is the midline of the body. So two clavicles, they meet over here. So यहाँ से यहाँ, this entire bone, medial 2/3 or lateral 1/3, this is the junction which is prone to break easily because this bone is S-shaped, right? So two curvatures, one is the convex and second is the concave. Two curvatures, they meet at this point. So that's why this point is more prone for damage. Then there is winging scapula, right? By the way,
There's a
one very,
pectoral.
yes, anyone ask something? Okay. One very interesting, say you asked this question, right? So reply is, okay, why in these PDF notes this image is there? And the thing is that after completion of this upper limb, when the lectures were taken, my hard disk crashed. I lost all the PDFs. So there was one student, he said, yes, sir, don't worry. You don't make the PDFs again, I make it, right? So he has taken the screenshots and then painfully he combined all the screenshots and then he sent the entire package to me. And then he said, okay, now you put into your Google Drive so that it is beneficial for all the students, right? And very unfortunate. That person was brilliant, but due to some reasons, वो मेडिकल में नहीं जा सका. मतलब जा नहीं सका. It is like because the parents, बहुत लंबी स्टोरी है, but it was like उसको support नहीं दिया. There were 3 kids in the house. Those 2 were given importance, and this kid was not given the importance. And he is into IT. He's into IT. उसको मैंने बोला be a good hacker. So time to time वो थोड़ा बहुत पढ़ता रहता है, कभी कभी ऑनलाइन आते हैं. So this is like, so I always remember. उसको मैंने अभी परसों ही बोला था. So इसलिए सर आप मुझे वो सारी हेट मेल्स फॉरवर्ड करो, कहते मैं उनकी बैंड बजाता हूँ. उनका नहीं करना. अच्छा. So I told him that it is like thanks to him from the entire batch for making such a good effort for all these notes. बाकी lower limb में you must have seen, right? उसमें all the notes, they are regular, because from that point onwards I started putting multiple copies of the notes, and they are on the cloud also, and they are into my NAS stations also. अच्छा. Then winging scapula. This is damage to long thoracic nerve, right? You must be knowing it so well. Because it is a long nerve, that's why it is more vulnerable for the post-op damage, and even in the radiation. Radiation, which radiation? Carcinoma of breast. Because in carcinoma of breast, the radiation is to be given locally at that point, right? So that's why radiation is something which literally penetrates. And when it penetrates, so that's why it will pick up this long thoracic nerve also, and will lead to serratus anterior palsy, and that leads to winging of scapula, right? Winging of scapula. So this is damage to long thoracic nerve, post-op, radiation, and serratus anterior, that is the muscle which is affected. Serratus means it is like this. Serrations, okay. Let's keep them. Let's keep them as vestigial organ. सही बात है. Very nice. So this is the serrations, right? These are the serrations. So these muscles, they look like those serrations. That's why the name is serratus anterior. Similarly, there is serratus posterior also. Serratus posterior. How many serratus posterior are there?
Superior and inferior.
मैं किसी से
Sorry,
पूछ
sir.
कोई बात नहीं. हाँ. On to the brachial plexus, right? Onto the brachial plexus, this is the point which we discussed. This is called as the Erb's palsy. And in Erb's palsy, ये question 100 and 1000% आएगा, which 6 nerves meet for the Erb's palsy, right? One, draw करके. So this is C5, this is C6, right? These are the roots. They form the upper trunk. In upper trunk, so that means we have got this C5, that is first one, C6, that is the second one, then suprascapular and now to subclavius. So this is 3, this is 4, right? And then they divide into anterior and posterior divisions, right? So this is 5 and this is the 6. So these are the 6 nerves which are involved in case of at the place of Erb's point. This is called as the Erb's point, and when the damage is over here, it is called as the Erb's palsy. For this, what is affected? So we have to remember it like arms 2, right? ARMS 2. S is twice. So A is axillary nerve, R is radial, then M is musculocutaneous, suprascapular, and then now to subclavius. Now this makes sense. Now suprascapular and now to subclavius, so directly. So that is what obvious, right? Axillary nerve, radial nerve, and musculocutaneous nerve. Now for this, right, just remember how the things they were getting formed. Axillary nerve, which was supplying deltoid and teres minor, right? So this is important, right? Axillary nerve will be supplying deltoid and teres minor. This is normal supply, right? Radial nerve will be supplying brachioradialis, extensor carpi radialis longus, supinator, right? And musculocutaneous, biceps brachialis, and it pierces that coracobrachialis. But here, this is the point which you must remember, right? Why it is? CB, coracobrachialis is spared as C7 is intact. Now see how it forms. This is C5, this is C6, this is C7, right? यहाँ से ये मिले, this is the upper trunk, this is the middle trunk, right? Then it divides into anterior and posterior, anterior, anterior and posterior. Now, so this is the root, trunk, division, cord, correct? And then this and this. So it will be making that lateral cord. This will be, right? Ha. And say C8 or niche, right? So that will be that anterior, that will be forming the medial cord. Acha. Now, in this, when it goes to the supply to coracobrachialis, right? It is the lateral cutaneous, which will be as the musculocutaneous, right? And then it will be giving the lateral root for
median nerve.
median nerve,
median nerve.
और ये median जो है, and this will be the bigger contribution from the medial cord, right? And then this one would be the
Ulnar nerve.
ulnar. Now, watch this. For the formation of musculocutaneous, this question is vital, right? ये कई बार, और this question can come as for the explanation that why the coracobrachialis is spared. When we see the formation of musculocutaneous, see this lateral cord is as such combination of what? Fibers which are coming from C5, fibers which are coming from C6, fibers which are coming from C7, right? That's how comes. Interestingly, for the musculocutaneous, the fibers which will be supplying to coracobrachialis, they come from C7. So that's the reason. Biceps and brachialis, they are straight away supplied by C5, C6, right? But for the C7, it is not so that for coracobrachialis, there are no fibers from C5 or C6. No, they are there. But the fibers from C7 also comes, right? C7 also comes. This is exactly like कि आपकी एक bulb है, उसके दो switches हैं, two-way switch. So if one switch is there, then there is even other switch also, so that can supply, right? Now in spinal cord, what happens? Will there be any weakness of the coracobrachialis? Not really, because see, in spinal cord, all these fibers, they will be going up, right? They will be going up. As such, so these are motor, right? So they'll be coming down. Actually, we should say like that. But why I'm saying going up? That means they are connected to the brain. These are the wires which are connected to them. Because they are supplying to muscles, so that's why they are all motor. So technically speaking, we should really say it like that in case of coracobrachialis, the fiber which is coming from the brain, it will be having exit from C5, it will be having exit from C6, it will be having exit from C7. C5, C6, if this is not working, no worries. Message from the brain that will go via C7. So that's why CB is spared, right? Coracobrachialis is spared. So as C7 is intact, out of C5 to C7, C5 to C7, which is needed for this musculocutaneous, right? So I hope this point is very clear.
Sir, is it
जी?
dual supply?
No, it is not like a dual supply. The now to एक ही जा रही है. There is only now. हाँ, if you think at a very say micromolecular level, so yes, it is like that. But it is, देखो, you have asked the question. This is our bulb, right? This is our bulb. थोड़ा ज्यादा हो जाएगा क्वेश्चन पूछना, but still, you know that there are different type of wires for 5 ampere and 15 ampere plugs, है ना? मतलब if you open the wires ना, तो एक में 5 एम्पियर में पतले पतले वायर होते हैं, but there is not one wire, multiple wires ऐसे हो जाते हैं, right? 15 एम्पियर में मोटे मोटे वायर होते हैं, but say it is exactly like these thin wires, but it is going at one point only. So आप बोलेंगे क्या, आप बोलेंगे कि एक वायर है ना, एक वायर, बट देर आर मल्टीपल वायर्स एग्जैक्टली द सेम वे. कंसिडर दिस एज अवर मस्कुलोक्यूटेनियस मसल एंड कंसिडर दिस एज अवर ब्रेन. मस्कुलोक्यूटेनियस मसल क्या, coracobrachialis, right? And this is our musculocutaneous nerve. So, but this musculocutaneous nerve will be carrying multiple fibers from C5, C6, C7, right? C5, C6, C7. So now एक ही है. When two nerves come ना, मतलब when the two nerves go, then we call it a dual supply. Right? Otherwise, with this logic, तो it will be having triple supply. कुछ को तो quad supply, penta supply ऐसा हो जाएगा. Then the anatomy will become very complex. Right? So when two separate nerves जिनका अलग नाम दिया जा सके, तो then we call it dual supply. Otherwise, this is single supply, but like this, but with the fibrous level. हाँ हाँ. घर का इलेक्ट्रिक वायरिंग मैंने खुद ही किया है. यस यस. व्हाट इज 15 एम्पियर? मतलब अपना जो रेफ्रिजरेटर, गीजर्स, ऑल दोज बिगर अप्लायंसेस, राइट. 5 एम्पियर में आपकी ट्यूबलाइट, पंखे, दोस एम्पियर. ये जो है, दिस इज लाइक पहलवान और दिस इज लाइक सिंपल आदमी. वोल्टेज तो सेम ही रहेंगे. वोल्टेज इज नंबर ऑफ इलेक्ट्रॉन्स विच आर पासिंग, बट वो इलेक्ट्रॉन कैसे, the number of electrons which are passing through that specific circuit in a specific given time, that is what generates the voltage, right? Potential difference, what is called as the potential difference. इलेक्ट्रिक क्लास हो जाएगा, but that is what is called as the potential difference. That's why positive and negative दो टर्मिनल रहते हैं. When these terminals they are fixed, we call it DC voltage, DC voltage, right? But there is lots of energy wastage when there is DC voltage. अपने सारे अप्लायंसेस, आपके जितने भी अप्लायंसेस है वो सब डीसी पे चलते हैं, वेदर इट इज योर लैपटॉप और वट एवर यू से, राइट. सब डीसी वोल्टेज पे चलते हैं, एक्सेप्ट ये आपकी लाइट, राइट. इसमें भी आजकल तो जो एलईडी आ गए, तो उसके अंदर तो यू विल सी दैट इवन वट एवर द इंटरफेस इट इज देयर, बट फाइनली देयर आर टू वायर्स. दोज टू वायर्स दे आर क्रिस्टली इन 5 वोल्ट डीसी or 12 volt DC, depending upon the number of LEDs per inch. ठीक है, but it is DC. आपका जो फैन है, फैन, that works on the principle of motor, right? Faraday's principle. So Faraday's principle was to generate electricity. So that is that this is the coil, this is the coil, and when this coil is placed between two magnets and you pass the current into this coil, so then that coil would start rotating. That is the principle of fan. आप स्कूटर में आजकल तो आपको एक एक नहीं मारते, बट अगर जो आपको बाइक में या उसमें किक मारनी पड़े, तो व्हाट यू आर डूइंग, दैट इज द प्रिंसिपल ऑफ डायनेमो. डायनेमो इज when you rotate this coil, when you rotate this coil, so then there is generation of the current, right? And that is what goes into the spark plug, and spark plug that generates current, and that this goes into your compression head, and this is where the, as you move the accelerator, right, that petrol that dips, that spark plug, it burns, right? It burns, it expands, and it pushes the piston, that piston which is connected to crankshaft, and that crankshaft is connected to gear, and then your wheel starts moving. Right? Same principle whether it is, and in electric cars, it is directly connected to servo motors. Servo motors means they can move very precisely. Right? You can control the sensitivity. So basically it is like DC. बाकी आता है अपना करंट AC, AC 220 volt AC. So why don't they give DC directly? Because the amount of wastage of current, it is very high in case of DC. That's why no one supplies DC. It comes in the form of AC only, and then it is converted to DC, right? So these are the things. कहाँ से कहाँ पहुँच गए? So, so this is the voltage, that is the ampere, right? फिजिक्स. सानिया, फिजिक्स इतना सारा आने वाला है ना, नो फिजिक्स नहीं. मेडिकल में एज यू विल प्रोसीड, इतना सारा फिजिक्स आएगा. And by chance, if you will be radiologist, तो फिर देखना कितना फिजिक्स आता है, फिजिक्स, न्यूक्लियर साइंस, सब सब। हाँ, so let's start with the deformity. This is the deformity which you know it very well, right? It is called as the waiter step, और policeman को बदनाम नहीं करना, but it is also called as policeman steps, or also as the porter step deformity. This is when we have got the OBS injury, right? The injury at the OBS point. So we start with the shoulder joint as discussed previously. We learn it in such a way कि खुद पे करके करना शुरू करते हैं. So first, shoulder joint. Shoulder joint is adducted, right? So it comes near. It is because of pectoralis major. उसने खींच लिया, right? Why? The reason, see, the deltoid, right, whose function was this abduction, wo gaya, right, is not working because axillary is involved. So that's why pectoralis major has come up and he has pulled the shoulder. Right, teres minor bhi gaya. So now there is no one who can really abduct. So now the shoulder is adducted. So it is near to the body. Then see the muscles, which are, all these muscles are affected, right? That means they are not working. Supinator. So this is the supination. Supinator is not working because supinator was a lone fighter, right? While in pronator, there was pronator teres and pronator quadratus. They will take over. So there would be the pronation, right? And extensor carpi radialis longus. Yaad karo. Carpi means rest. Extensor carpi radialis longus. Long muscle going on the carpals, whose function is extension. Gaya, right? So extensor is not working. So flexors will work.
Next.
Yes. So there will be wrist drop, right? So with this, it is easy to figure out that what would be the position. Adductors and medially rotated, right? Adductor medially rotated. Elbow is extended, right? Because biceps has gone. Function of bicep, brachioradialis, that was to flexion. Flexion is not happening, so that is extension. Forearm is pronated. Yes, pronator teres and pronator quadratus, because supinator bichara akela lad raha tha. Now he is not in the picture. And wrist is flex, extensor carpi radialis longus, who was leading to extension of the wrist. Now it is not working. So flexions, right? So that leads to flex. This position is called as the Porter step deformity. And yes, it is expected when it is asked that you should be able to answer all these, right? All these 1, 2, 3, 4 points at every joint level. So causes fall on outstretched hand, or the bigger complication is during the obstetric complications. In obstetric complications, when the hand is pulled, right? So it may lead to all these minor defects. But say in nerves, it is like sometimes only the outer sheath is damaged. Outer sheath is damaged, and that is recoverable. Both those Schwann cells, they recover, and within 4 to 6 weeks, the person would be completely fine. But if during your ops rotation, right, you keep an eye for all those. Say in case of cesarean operation, this thing won't occur, because in cesarean, to straight away the incision is put and the baby is delivered, right? Baby is taken out. But in normal delivery and in cases of this complicated, say, operations, or when you see, when on ultrasound, you find when the pelvic size is very small, right, and the baby is healthy, so then it can lead to all these things. So this is like your observation, and when you watch, you'll find that baby into this position, right? Keep a track on that, and that baby will be fine when that baby will be coming for the follow-up, that after 4 or 6 weeks, right, you'll find that it is for. But if it is not, then you need to investigate it further. But in most of the cases, baby recovers. This is Klumpke's palsy. Klumpke's palsy, this is the lower trunk, that is CAT1. We are talking about this part, right? Now the damage is over here. This is because of the hyperabduction. That means someone is falling and then he's holding a tree bachne ke liye, and in that literally this lower one is peeled off, right? So this is like median and ulnar, now they are damaged. Now you know it very well that median and ulnar now, as we said, that वो तो बस मस्ती के लिए आम में घूमती है, right? बाकी का काम तो नीचे है, right? So ये तो मजे मजे से they just move. they affect intrinsic muscle of hand and the wrist flexors and the finger flexors, right? Median and ulnar. We know it very well, that median nerve and ulnar nerve, right? So they are there. So here is, it is this, right? Obstetrically, when sometimes the baby is to be pulled, it is especially when there is a shoulder presentation and then the hand comes out and then head is big and the hand is pulled. Nowadays, you won't find this thing very common, because if it is like this, so then incision is put or the forceps are used and the baby is given the space and baby is delivered. But this is very common. This is very common, right? When fall or in many of the sports, right? When try to pull, so then it can lead to all these. Are those images from this? अच्छा वो तो बात हो गई. अच्छा इसलिए नहीं बना. Aman? Yeah, thank you. Pelvis being small, okay, good question. The pelvis being small, so what happens that if the pelvic size, we'll study it in more detail into obstetrics and even when we'll be discussing the pelvis, abdo-pelvis. But there are certain, say this is, right? These are the iliac crest and ischium, pubis, right? The uterus, fallopian tubes. Now, the bony structure, right? There is something what is called as the true pelvis and the false pelvis. Again, nothing like wrong or real or unreal, but it is like that pelvis which will be giving place to the newcomer, to the baby, right? Now, say this is the room in which the baby would be growing. When the baby grows, right, that baby, it has got ample space and it will grow. But when it has to come out, it has to come out through that narrow space, the birth canal, right? It has to come out through narrow. And now there is tremendous capability of the female uterus to stretch, right? It has got tremendous capability. It gets delivered, right? This is normal. But in some cases, if the size of the pelvis is smaller, so then uterus has got the capacity. But what about the bones which are over here? Right, the bones which are over here, because bones, they cannot go beyond certain limit, right? Whatever you do, bones cannot go. So that is the point when it can cause some trouble, right? Though nature has got amazing compensation, but still in many of the cases, right? And you know these things in advance, especially when you do ultrasound, right? So you can easily CRP length and all those lengths, you can measure it very easily and you can predict certain things, especially in high resolutions. So you can, so even I got about more than 1,000 ultrasounds of this, more than 1,000. Right? So I can show you when we'll be discussing obstetric or even in abdo-pelvis, all those things, they can be seen. So you need to see it once and you'll always remember it. Achha. So coming back to this, so it affects intrinsic muscles of hand and wrist flexors and finger flexors. So it results in what is called as the claw hand. So claw hand, forearm is supinated, right? Forearm is supinated, hyperextended. Now see, who is acting? What has gone? The gone thing is pronators, they are not working, flexors, they are not working, because wrist flexors, finger flexors, they are affected, right? So iski ulti movement, that is the supinator, which will become dada, right? This extensors, they will become big boss. So wrist and metacarpophalangeal joint, and there is flexed IP joint. Interphalangeal joints, right? They are flexed, but baki sub-extended. So typical claw, right? See, baki ka sub-extended, right? Extended like this. But then only these tips, they are flexed. Kyun? There is wonderful reason. Very wonderful reason that how lumbricals they come, and on that there is extensor digitorum. Right? We'll come to that just within few minutes. But do remember, ye figure, right? Or khud bana ke, literally panja, right? Aise, right? When you make it. And think it from the medical terminology. This is what, this is, So this is distal interphalangeal joint. This is proximal interphalangeal joint. And this one is
Metacarpal.
metacarpophalangeal joint. यहाँ से सारे joints extend. And then these two flex. Automatically you will get the claw. Right? Do remember this. Right? This explanation, this one and this one. Right? It will be asked time to time. It can be asked in YY. It can be asked anywhere, even in questions also. Is this going to be in the folder? हाँ अफजा बिल्कुल रखेंगे. ये होगी. Muscle can be pulled because of the transition muscles. हाँ, that's right. That's right. आगे. Right. So this is DIP. This is PIP. They are flexed, and बाकी के सब they are extended. So that is how it really looks like. This is the master stroke, which everyone might be missing. In brachial plexus, as we said, that there is T1. Just give me a second. Be back in less than a minute. Yes, back. So what I was telling was that in brachial plexus, when this injury is there, the T1 fibers are involved. So for the sake of simplicity, I've just added something, right? Sympathetic and parasympathetic. Sympathetic, they are called as the thoracolumbar. T1 to L2, right? So in entire spine, right, we have cervical, thoracic, lumbar, and sacral. Right? Cervical, thoracic, lumbar, and sacral. It is this region which is called as the sympathetic. Now, sympathetic fibers, they are for stress, right? Thoracolumbar, T1 to L2. It is this T1 which is involved, right? By the way, parasympathetic is cervico-sacral. And in cervico, we'll be talking about those cranial nerves, classically 3, 7, 9, and 10. These are the part of parasympathetic system, right? Parasympathetic, which is rest and digest. Say, for example, number 10 is vagus, which is for the abdomen, all the organs, right? Digestive organs. So this is the rest and digest. Rest and digest. Right? And sympathetic is for stress. So this T1 is involved. When we say sympathetic is for stress. Stress is when body is on alert, that means eyes would be wide open. We want more light to come into our eyes so that we see the picture clearly. Right? The muscles, they are getting more blood supply so that either they can fight or they can run away. Right? Survival is important in this case. Because survival is important, so that's why digestive system, it will say, okay, no blood will be given to you. You don't need to digest those sandwiches right now. Right? And body would be sweating because circulation increases. Heart is pumping faster. You are breathing faster, right? So all these things, they are the classical of sympathetic fibers, right? Sympathetic system. The pupil, which is dilated, it is also called as the mydriasis, right? Mydriasis. But now T1 is lost. T1 is lost, and it is T1. Because you might ask the question that will the digest system be affected? No, digest system will be affected because we have got T1 to L2, right? So it is in between this T11, T12, L1, L2. They will be the suppliers for the digestive system. Then T7, T8, they will be supplier for the heart. So that means when T1 is affected, T1 will be affecting what? The highest thing. Highest thing is like our eyes, right? So eyes, which should be wide open, pupils which should be dilated, and sweating, face sweating. Those things are cut off because T1 is handling them. And when the T1 fibers are affected, so it will lead to the situation what is called as what is comprising of ptosis. Ptosis means upper eyelids, right? Eyelids जो पूरी wide open होंगे, उसका उल्टा. They are drooping as if person is sleeping. right? Drooped eyelids. Meiosis, which is reverse of mydriasis. Mydriasis, dilation of the pupil. Meiosis is small pupil, right? Ulta ho gaya. Sweating should be there. There is anhidrosis. No sweating on face. Remember, on face, right? Don't confuse. Rest of the body is normal because this is T1 only we are talking about. So it is anhidrosis. These are multiple things, right? They can occur individually, but here they are occurring together. So that's what is called as the name as the Horner syndrome. Horner syndrome means collection of signs, symptoms, right? So that is what is called as a Horner syndrome. ये तो स्मॉल प्यूपिल मुझे याद नहीं रहता था, ये सही बात है, मैंने यूट्यूब पे भी बोला और यहाँ पे भी मैं सही बोल रहा हूँ. स्मॉल प्यूपिल इज मायोसिस वो नहीं याद रहता था, गड़बड़ होती थी. तो देन आई फिगर्ड आउट कि स्मॉल प्यूपिल मतलब इट इज वो बेचारा मायूस होके दुखी आत्मा करके ऐसे करके बैठा है, राइट? तो दैट इज मायोसिस. सो ऑब्वियसली द प्यूपिल्स विल बी स्मॉल. फिर कभी मिस्टेक नहीं हुई. This fourth thing is very interesting. It is called as the loss of ciliospinal reflex. Ciliospinal reflex is that if you scratch the neck, right? If you scratch the neck, right? So then कोई जोर से कहता ah, right? So eyes are automatically, right? Pupils are dilated, right? This is what is called as the, because this is a painful stimulus. जोर से करता right? What? So this reflex is absent in Horner syndrome because again it is governed by T1 and lesions involving the cervical sympathetic fibers. Obviously, cervical sympathetic fibers तो वो बहुत आगे की बात हो गई, right? When there can be some SOL or there can be some injury, some track injuries, that's a different story. But it is absent in Horner syndrome. Remember, important thing is it is not necessary that all the four things should be there, right? Sometimes two, sometimes three, right? Some things are into advanced level, some things are into less level, but ptosis and meiosis is usually you will see very commonly. So that is what is called as the Horner syndrome. On to the radial nerve. Now starts our circuit wala part, right? Literally circuit. Achha. 1, 2, 3, 4 messages from you. I was trying to connect medial head or triceps. हाँ ठीक है. C4 if affected, phrenic nerve is affected. बिल्कुल phrenic nerve is ipsilateral dilatation. Yes, ipsilateral, same side. Yeah, that's right. Because in eye, right, that crossover it occurs at very high level, just after, right, those optic chiasma, and then it goes like this. So it goes like this. It goes like this, like this, like this. Right, very interesting. That circuit. Huh. So we move on now to the circuits. Circuits kya? These are the nerves, right? So now radial nerve. Radial nerve, we know that the moment we say the radial nerve, immediately yaad aa gaya, right? That it will be passing through this radial groove, which is associated with shaft, and it is on the posterior side, right? And so let's say radial nerve damage, if it is low. Low means it is below the elbow, before it is getting going into divisions. कौन से division? Superficial and deep branch, right? Superficial and deep branch. Muscles which are not affected, कहाँ से affected? Because radial nerve supplies triceps, because it's a posterior nerve, right? Supplies triceps, supplies anconeus, brachioradialis, brachialis, ECRL, all posterior, right? But these are the muscles which are getting supply at much higher level, right? So movements are not at all affected, right? Extension of elbow, wrist, all are normal, right? Not affected. Hence, wrist drop is not seen because wrist drop kahan se dekhenge? Wrist is dropped when ECRL, extensor carpi radialis longus, is affected, which is taking the wrist back, right? This ECRL is so fine, healthy, right? So there won't be any wrist drop. But what would happen? There would be loss of sensations, right? Because these are the superficial and deep branches. So this is, right, now seen in, so seen in upper injury of radial, right? When it is upper injury, so here the loss of function would be definitely there. Sensory loss, so yes, hoga, but then it will be affecting the unable to extend MP joint, metacarpophalangeal joint, right? Metacarpophalangeal joint. We won't be able to extend because because the extensors are involved, so flexors, they have become big boss and they have taken over. So now there would be effect, or they will be affecting. Superficial branch of radial nerve, this passes below brachioradialis and it is sensory supply to lateral 3.5 digits of dorsum, correct? That is the radial nerve. Now you remember when we were telling 3.5 and 1.5, right? How it was happening. So this is the 3.5 digits of dorsum. This is dorsum, right? And we are talking about the radial nerve. So 3.5 digits they are supplied. Compression of this superficial branch of radial nerve that is under brachioradialis. So branch can get affected. If this branch is affected, yes, we know that it will be affecting the sensory portion of the dorsum. So क्या होगा? Loss of sensation in lateral 3.5 digits. Correct? Lateral 3.5 digits. Now this is the point where I added something extra. As there was one question, and it was a very tricky question which was asked in last year's USMLE, talking about Wartenberg syndrome and the Wartenberg sign. Kuch nahi hai. It's like as such, if once you will be coming into surgery, so you will be knowing it extremely properly, but still good to know. Wartenberg syndrome and Wartenberg sign, naam hi same hai, baki kuch same nahi hai. It is only the name which is similar. The major difference between both of them, right? Watch this. The major difference between both of them is that Wartenberg syndrome, right? There is no motor weakness. There is no motor weakness. There is sensory weakness. There is only sensory weakness, right? When it is sensory weakness, sensations are normal, so then it is called as the paresthesia, right? Sensations have decreased, right? This is AK, also known as chiralgia parasitica. ये तो नाम याद रहे तो ठीक, otherwise no worries. But this is just, it was asked in like this. Anyway. So what happens in case of this Wartenberg syndrome? One thing is clear, there is no motor weakness. That means muscles will not be involved. So there would be compression of some nerve, which is just giving the sensory supply. So here it is the superficial branch of radial nerve at rest, right? This is affected. Because superficial branch of radial nerve at rest, its final function is just the cutaneous supply, right? So that would be affected. This is where it is at the rest, right? It is at the wrist. We are talking about the radial nerve. So on the radial side, over here, on the outer aspect, here, if anything happens, right? What can really happen? When this nerve, this superficial nerve is involved, it can be involved in, जब जेल में कैदियों को, now there are handcuffs, right? So when the handcuffs, they are applied, so in handcuff, you know that there is a lock, right? There is a lock. इसके अंदर चाबी मार के ऐसे घुमा देते हैं, right? So it is locked. Now that lock, it because it is a round thing, na, and those police wala, they will not be knowing it. So this is the handcuff. Either the lock is on this side, or the lock is on this side. Correct? मतलब this is the handcuff. Either the lock is on each side, or उसने rotate कर दिया तो lock is on this side. When the lock is on this side means lateral side. So that lock, that is the extra metal which will keep on compressing. It will keep on compressing. अब उसको central jail से transfer कर रहे हैं, right? So he'll be sitting like this into the van, खखड़ 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 हो रही है van. So this is like a common constant injury. जेल पहुंचे निकाला तो उसका हाथ ही नहीं चल रहा है, इसे अरे साहब दर्द हो रहा है, right? No one would listen to him, but this is the thing. So this is what can occur in case of handcuff, right? Remember, patients कभी झूठ नहीं होते. They are never wrong, right? When someone is troubled, then and then he or she is telling. Then second is cast, right? When there is fracture, so then यहाँ पे, when the plaster is applied, this portion is given in, that will learn in orthopedics, a small nick. मतलब पूरा plaster लगा दिया, then take scissor and just put a small cut, so that this area is not compressed. If that cut is not applied, so then that can lead to this Wartenberg syndrome, right? Then using the tools, those who are watching the Charlie Chaplin movie, right? The movie was Modern Times, right? Modern Times, right? He was just working in one of the factory, and that was his function, right? Every time he was tightening the screws, right? So wherever he'll see those round black things, so he'll just go behind and going for the tightening of the screws. Tool use, constant use, right? So that will lead to this Wartenberg. Then cycling. Yes, very true. Cycling. When you are going for high speed cycle, right? Especially, say I use mountain bike, which is with 27 gears, but the trouble is it is a heavy bike, right? So when you are holding it and then you are going for a long distance, about 70, 80, 100 kilometers, so for almost 4 hours, right? You are holding it like this. So this is like a constant pressure, constant pressure. So by the time when you finish, right, you feel like, haath mein dard ho raha hai, right? It happens. This is like that. Or the direct trauma. So that is not a rocket science. So these are the things. Why I explained this? Because this is the topic of orthopedic. We finished it, right? So this is the Wartenberg syndrome. And in Wartenberg syndrome, the idea is it is this area, compression of superficial branch of radial nerve at wrist, that is involved, and it is purely a sensory thing. Right? So what would happen? This would be numbness over the dorsal radial hand. Numbness, or it is also called as the paresthesia. Paresthesia at the dorsal, that is at the wrist, right? Dorsal radial hand. So that's where it will. This, they frequently report symptoms magnification with wrist movement or with tight pinching of the thumb and index. Obviously, no? If there is movement of the wrist, pain is like a protective phenomena. So if there is more movement of the wrist, to or dard hoga, right? Because this is simply because of the compression. What really happens is it sets inflammation. Inflammation means there would be swelling, there would be redness, there would be increased blood supply, there would be pain. Pain is a defense mechanism so that we don't use that part more, right? So that's why it is a defense mechanism. Against this Wartenberg sign, that refers to purely motor. And in what? Ulnar nerve is dysfunction. Ulnar nerve is involved. So this is a clear difference. This refers to slightly greater abduction, and this is very typical. This is a question which can be asked. In Wartenberg sign, the hand would be like this. Hand would be like this, right? This would be the hand. The little finger, right? Fifth digit, there would be slightly greater abduction of the little finger, right? Why it happens? Paralysis of adducting palmar interossei, right? We know this, that pad, right? Pad. Palmar interossei is there for adduction. This is adduction, right? This is adduction. But this palmar interossei, that is affected, right? And then there is unopposed action of the radial innervated extensor digiti minimi. Now for other fingers, there is no problem because there are other muscles which are taken care of. But यहाँ पे, you know, there was one extra muscle that was extensor digiti minimi. मतलब वो जिद करके वो छोटी finger ने कहा नहीं मेरे लिए एक muscle चाहिए, right? So that was the extensor digiti minimi. Now this muscle becomes powerful. It comes into action. So this is like, as such, there is weak adduction, but then because extensor digiti minimi, that extension comes and it goes back. So typically this is the situation, right? It is not, if I show you inside, it is not like just like this, it is slightly back. This is classical Wartenberg sign, right? And when you know that, definitely there is involvement of the ulnar nerve dysfunction, right? And the culprit is EDM, extensor digiti minimi, because it will be affecting only the little finger. Okay, now there are several, these are called as the spot diagnosis, right? They come under spot diagnosis. Diagnosis is written as DX. Spot diagnosis. Spot diagnosis are those pictures or those images which will be appearing. They are very common. They will be appearing in your many of the competitive exam. They'll be appearing into your all this USMLE, PLAB, वगैरह, right? Because just one image is given and then you are given the options. Right? So yes, you need to understand and remember, right? Their mechanism of action. And trust me, they are like, बस ये नाम याद रखने जरूरी है, because नाम अजीब अजीब से नाम आएंगे, right? So one which is called as the mallet finger. Mallet finger This is deformity of the finger caused when the tendon that straightens finger, that is, who will straighten the finger, right? These are the flexor and these are the extensors, right? So extensor is damaged. Simple as that, right? बड़ी सीधी बात है. Extensor damaged, so that's why finger are flexed. This is, many of the boys must have experienced it. वो कैच करने गए, right? And judgment थोड़ा change हुआ and ball यहाँ पे लगा. And right? And then पता चला कि बस by the end of the match तो उंगली ऐसे हो गई and then huge swelling. Correct? Or sometimes when you play volleyball, right? So when you try to put a smash, तो उधर भी वहां पे that ungli is involved, right? So time to time, in multiple sports, this thing can occur. Can occur even मतलब बहुत, I'll say, when a ball or other object strikes the tip of the finger or thumb and forcibly bends it. Now, forcibly bends it, the force tears the tendon that straightens the finger. Because when you are catching the ball, so your fingers are tight, right? Matlab, and then against that pressure, that ball has forcibly bending it. Now, if it is forcibly bending it, nothing would happen to the flexors because as such, you are bending in the direction of the flexor. But this extensor is trying to straighten it, and then ball's pressure is trying to bend it because everything happens in split second. So that's extensor tendon that splits, it breaks, right? This can occur even in very aged, very weak people. Inflammatory arthropathy. Inflammatory arthropathy. I saw recently one such case and his age was just 32. Inflammatory arthropathy, right? As he was trying to do some exercise in the gym and it led to break of this tendon. And then the D3 was checked. Wartenberg syndrome permanent or is temporary? It is temporary. Usually it is temporary because that nerve recovers, right? All those compressions. See, remember, it is not. If the damage, I mean, if the injury is like किसी ने चाकू से काट दिया, if there is cut, right? So then nothing can be done. But when it is compression only, so then it recovers. So I was talking about this inflammatory arthropathy. His D3 level was just 4. His D3 was 4. That's why I was insisting all of you that remember your B12 and D3, they are vital if you really want to be very successful in your studies. Because B12, that would be important for your brain function, and D3 will be very important for your physical fitness. Because if the physically person is not strong, तो फिर brain कहाँ से strong होगा? मतलब brain is super strong, wonderful, but your body is not supporting. After some time, you'll feel tired and ulte hoke soye ya aise tede mede. So then that's not the way we should really study, right? So that's why this should be, what should be the ideal level? Yeah, I was expecting this question, right? Ideally, you all are in the best phase of your life, right? Your body engines, they are amazing, right? They are at the best level. Minimum level I'm writing, so minimum your levels should be 500, right? And D3, it should be at least 45 plus. If it is 50, 55, 60, nothing like that, then your bones are super strong. And yes, your reports, which I saw in some of the cases, it was below 10, right? That's a crime. That's a crime. Khao piyo, theek se khao. Right, just a minute. Sparsh, that has happened with my friend while playing basketball. He was a doctor, now he can't play. Arey, wait. You raised a very good question. People जब ऐसी ऐसी उंगली मुड़ जाती है तो जैसे कह रहे हो जाएगा ठीक, नहीं होता, because the tendon is ruptured. Once it is ruptured, right, if it is not say taken properly care of, or care kya, you have to actually go for a surgery. Right? You have to go for the MRI. In MRI, you'll be able to see the degree of tear. So then surgery is very simple. Just you remove the skin and then the cut ends, they are sutured together. And then within 3 to 4 weeks, right, everything is fine. And then the movements, everything becomes normal. But if not done, so then they will diffuse. And once they are diffused, that deformity, that will remain permanent. Then it becomes overtly complicated to repair that thing. It's not that it cannot be, but then you have to put the artificial tissues in between, because those ends now they are lost completely, right? They are diffused. And in case if there is any injury of the blood vessel, so then it becomes still more complicated. Uh, yeah. So here, because this only the tip is involved. Only the tip is involved. Now you remember who will be responsible for this flexion? Which
Flexor
muscle?
digitorum
It's a
profundus.
digital profundus.
Very good, very good. Because it is the flexor digitorum profundus who is going all the way to the distal phalanx, right? Otherwise, flexor digitorum superficialis, so it is ending at this point only, right? So that's why this would be the key question, that when it comes to, say, mallet finger, questions can come in this way. One, in mallet, you are shown the image and you are given the option that what it is, Wartenberg sign, Wartenberg syndrome, mallet finger, right? All those. So yes, that can be one question. Second question, you are shown the figure and then you are flexor digitorum superficialis, flexor digitorum profundus, extensor digitorum superficialis. So that way the options will be given and you have to select that which tendon would be involved. So that's how it goes. And in competitive exam, mostly नहीं 100% यही आता है, ball has hit. This comes very rarely. No one will ask you this thing in exam. This is just the real world. This is what is called as the inflammatory arthropathy. Arthropathy, right? Arthro means joint. When the joint is getting disintegrated and then the inflammation sets in and then the person is unable to. But in that case, what really happens is the multiple fingers are involved. If you look at the opposite hand, and usually there would be a history of injury, but that injury would be very minor. Jara si injury hui. In aged people, you must have seen bathroom mein jara sa slip hue and their bones are broken. Which bone? Commonest bone. This is the head of the femur. The neck is broken, right? And that becomes one of the most painful thing because it heals very slowly. And then rest of the life, they remain in bed only. Or even if everything is done, you'll find that their movements become very sluggish and life becomes very much dependent. This one is called as the swan neck. Swan means apna batak, right? Swan, right? Swan neck deformity, right? Now you see swan is a very gracious bird, right? Very, very beautiful bird. So this swan neck deformity, this is, see the image which I have drawn. There is bending in or the flexion of the base of the finger. Base of the finger, matlab, this is called as the base, right? Base of finger, right? Fingers, they are connected to this metacarpals, right? So this is the metacarpal. So this is the base of the finger. Now साथ karte jaiye. Bending, that is flexion at the base of the finger. A straightening out of the middle joint. Middle joint matlab kaun sa? Middle joint matlab this PIP, right? So straightening out. So this is the hand bending in between, straightening of the middle joint and bending in flexion of the outermost joint. Outermost joint means this is the DIP, right? This is outermost. Uske baad there is no other joint. So here, right? So this is how it looks like, right? So over here, PIP, this is straightening out, extension, or sometimes it is even hyperextension. So here it goes like this and like this, right? Like this. So one finger which is going like this, that's how it goes. So here it is shown, because in normal course, you will, even if you try to do it, you won't be able to do it, right? Because the joints, they are so powerful, so they won't let it happen. But here it is. MCP, metacarpophalangeal joint, see there is flexion, right? This is flexion. Then there is hyperextension at PIP, correct? This is hyperextension. And then at DIP, distal interphalangeal joint, or the last joint, this is flexion. And this thing is called as the swan neck deformity, classically seen in rheumatoid arthritis, right? Classically. And if you move to civil hospital and you see aged patients, right, you will see so commonly, right? Rheumatoid arthritis, right? चल रहे होंगे, and that's why they are called as the spot diagnosis. देखा and then you diagnose. Then this is what is called as the boutonniere's deformity. Both easier, right? This is usually a result of, first we see the trauma. This is usually a result of trauma in the acute setting, right? Trauma in the acute setting. मतलब आज यहाँ पे only little finger that gets damaged, right? I'll show you how. And is caused by rupture of the PIP central slip. Now you remember, all our joints, they are well secured, right? Well secured with those fibers. There were two types of fibers. One which was the circular, right? And that was called as the annular fibers, or under annular ke andar there were cruciform. So cruciform, and then the whole thing is packed and in the form of annular fibers. So that's how every joint is protected. What if these slips, these central slips, they are ruptured? This is what really happens. So here, the finger is flexed at the proximal interphalangeal joint. Bilkul, PIP, it is flexed. So finger is like this, right? And hyperextended, this one at interphalangeal joint. That is the distal interphalangeal joint, DIP, right? So this is hyperextended at DIP, and this is how it looks like. Now, normally when you'll try to do that, you won't be able to do it, right? Even if you will try, right, without touching your finger, you won't be able to do it. The reason, the flexors, right, and the extensors, they are in absolute balance. So even if you try, you won't be able to do. But then this is the situation. This is how finger would look like. This is called as the boutonniere's deformity. This is class question and asked many times, because there is a very clear difference between two conditions. And for this, your knowledge of anatomy is vital. All you need to remember is, you remember extensor retinaculum. We talked about extensor retinaculum. In extensor retinaculum, there were 1, 2, 3,
6 chambers.
6. That's right, 6 chambers. Out of those 6 chambers, 1, 2, 3 chambers, they were related to which structure?
Anatomical snuff box.
Anatomical.
Anatomical snug box.
Yes. Now, all you need to remember is what was here, what was here, and what was here, right? So, boundaries of anatomical snuff box, they are made by chamber 1 and chamber 3 structures. And then there are 2 structures which are passing through the chamber 2, right? Plus, you have learned 2 major conditions. One, what is called as the dequervant tenosynovitis. Whenever we say tenosynovitis, tenosynovitis, we are dealing with the tendon, and synovitis means synovial sheath, right? The sheath which is covering. Whenever it comes to itis means inflammation. So one is the tendon is inflamed, but the sheath around it is normal. When sheath is also involved, right? When the inflammation has increased so much so that when you see the hand, then all the joints, they'll look bulky, right? And when you press them, right, so they'll be pretty soft, but they will be warm, right? That's why when you will be examining such patients, you'll be using your ulta, haath ka piche ka portion, because the nerve supplies, nerves which are present over here, they are more superficial as compared to over here because of the palmar fat, right? So fat is over here, so that decreases. But this portion, that's why देखते हैं कि किसी को बुखार है, हाँ यार ऐसे करके देखा, right? We touch like this, right? So this, when you touch, you'll feel warm. So that is the confirmatory sign that it is the inflammation which is into this. So anatomical snuff box, that is the lateral boundary. This is into the first compartment of extensor retinaculum, right? And these were the things. Abductor pollicis longus, abductor, right? Because it is lateral, right? Abductor pollicis longus and extensor pollicis brevis. We are dealing with pollicis, right? Thumb, because this is the extensor retinaculum, and we are talking about the thumb. Thumb is laterally. So one is abductor pollicis longus and the extensor pollicis brevis. These were the lateral boundaries of anatomical snuff box. Involvement of tendon and its sheath of both above muscle, that is what is called as the dequervant tenosynovitis. Remember both these muscles, and there is involvement of tendon and involvement of sheath, right? This is the precise definition. Important, because options will be like involvement of tendon of abductor pollicis longus, involvement of tendon of extensor pollicis longus, involvement of tendon and sheath of abductor pollicis longus, right? Now, when such 6 options are there, all look same. So when it is said tenosynovitis, remember tendon and sheath and both the muscles, right? So to remember. ये तो universal. When you take say painkillers, so you get gastric irritation, right? Boli dene ka. So same way, whenever you talk about any of the inflammatory thing, invariably, like a very smart super student, say repetitive hand or wrist movements can make the condition worse. Wah wah wah, right? So this is like a wah wah thing. Obviously ना जब मतलब चोट लगी है तो then give rest, otherwise my shoulder is injured and I say नहीं I'll be going for the deadlift of 100 kilogram तो बेटा और खराब होगा, right? So this is repetitive hand or wrist movement can make the condition worse. What's a big thing? The main symptoms are pain, obviously, itis, inflammation, and tenderness. The difference between pain and tenderness is pain is when the patient चिल्लाइफाइज कि यार मुझे दर्द हो रहा है. टेंडरनेस इज व्हेन यू से अच्छा दर्द हुआ, पेशेंट पूछने की जरूरत ही नहीं है, उसने आ करके जोर से चिल्लाया. सो टेंडरनेस इज व्हेन यू टच द पेन कम्स एंड पेन इज व्हेन पेशेंट इटसेल्फ सिंग्स द सॉन्ग कि दर्द हुआ दर्द हुआ. बिलो द बेस ऑफ द थंब, राइट? बेसिकली कहां पे? Anatomical snuff box, right? That's the point. Base of the thumb. That is where these two tendons they are originating. Treatment may include medication, yes, painkillers, physiotherapy, that is the rest, icing, compression, and elevation. हाथ ऐसे रख के, right? Treatment is generally successful when begun early, obviously. When situations they go worse or ज़्यादा damage हुआ तो result would be accordingly. Tendinitis is the inflammation of tendon, right? Often developing after degeneration. That is what is called as the tendinopathy. Whenever you use the word pathy means that particular thing has degenerated. It has damaged fully, right? Chances of recovery becomes decreased. So itis is inflammation of tendon, but tendinopathy means it is degeneration. Similarly, when we say tenosynovitis, it is synovitis is tendinitis plus the sheath is involved, right? So symptoms usually include pain with motion and tenderness with palpation. See, you got the idea over here. Pain with motion, right? Patient is moving and is telling, dukha. And tenderness with palpation, right? Inspection, palpation, percussion, and auscultation, right? What was percussion? What was percussion?
Knocking.
Knocking.
Very good. Here it is. इसके अंदर बी रेडी, पेशेंट जो है वो कौन सी एरिया में से है एंड अकॉर्डिंगली ही विल बी गिविंग यू अ शानदार गाली, राइट? दिस इज द टेस्ट फॉर दैट. सो दिस इज द फिंकलस्टेन्स टेस्ट. एक तो दर्द हो रहा है, ऊपर से आप उसको और दर्द करवा रहे हो, right? This is a test which is used to diagnose Dequarian tenosynovitis in people who have wrist pain, right? Patient has come that अरे दर्द हो रहा है दर्द हो रहा है, right? And what you do is table के corner, this is the table and you say कि rest, right? मतलब ऐसे रेस्ट दिया, I'll show you from this side, right? So रेस्ट दिया, मतलब wrist is down and then you hold the thumb and खींचा जोर से. When you pull it, right? When you pull it, so obviously this is the spot, right? That is the spot which will give sharp pain because that will be abductor pollicis longus and extensor pollicis brevis. They are affected. And patient will say, and uske baad start, kuch bhi bole, right? Because yes, that would be that painful. So if sharp pain occurs along the distal radius, this is likely. Right? किया था एक बार, वो इतने जोर से बोला, ओ साहब, मतलब बाहर ओपीडी में बाकी के सबको सुनाई दिया. So to be done very carefully. उन्होंने यूट्यूब पे ऐसा बोला था कि वो ध्यान रखना क्योंकि पेशेंट का दूसरा हाथ ठीक है, राइट? वो मार ना दे. इफ यू अटेंड द ओपीडी ऑफ सिविल हॉस्पिटल ना, ये दुनिया भर के लोग आते हैं, तरह तरह के लोग आते हैं। आई मीन यू आर वॉचिंग अबाउट 100 पेशेंट्स अ डे। ऐसे ऐसे दिमाग के आते हैं। एंड देन द सीनियर्स दे विल बी आस्किंग यू द क्वेश्चन, which sign is this, which tendon is involved. उसमें लच्छा मारा तो और गाली। अच्छा, this is a trick question, this one. The oarsman's rest and the dequarian. We move on to our this concept. That was the extensor chamber 1, extensor retinaculum chamber 1, extensor retinaculum chamber 3, and in between is the chamber 2. Right? Abductor pollicis longus and extensor pollicis brevis. When that is the condition, so we know this part, right? That it was dequervin. So this is the first compartment in which there was tenosynovitis. Fine. So these two, that is the abductor pollicis longus and extensor pollicis brevis, they are involved. Chamber 1, remember chamber 1. Now, this is the involvement. This is called as the intersection syndrome. Pain and everything would be very similar. यहाँ ड्रॉ करने में थोड़ा इजी लगता है कि हाँ, yes. In real life, when the patient tells that pain is here or pain is here, वो patient, ये तो आप हैं, मतलब you know the difference between chamber 1 and chamber 3. How the patient tells, साहब यहाँ दर्द हो रहा है, यहाँ. अब यहाँ मतलब कौन सा, आप बोलो कि इधर या इधर, अरे यहाँ दर्द हो रहा है. You ask 10 times and they won't. Right? It is you who has to take a judgment. The thing is, in this chamber 2, there is ECRL, extensor carpi radialis longus and brevis. They are traveling. Correct? Remember that? Right? They were traveling. It is this chamber 2 which is involved. Right? So there is pain, swelling, and crepitus worse during flexion, extension, and twisting movement of the wrist. यहाँ पे, in the dequarian, it was like when you move like this, so then it was giving trouble, right? But here, so this is where you'll say, you'll tell the patient, ऐसा रख के खींचा, दर्द हुआ, right? But you'll find that pain is there, but not that much. But if you say now, you bend the wrist and extend it, and then the patient tells, yes, there is a pain. This is the difference. In one case, you are just involving the thumb, and in second case, you are involving the entire wrist because of the tendons involved. Extensor carpi radialis longus and brevis, they have crossed each other. Right? And this is a natural thing. They have crossed each other, or there is inflammation. So that's why any movement which will be related to carpals means wrist. So when the wrist is getting extended, that will give pain. So pain, swelling, crepitus is if you touch, right, you will even hear. Right now when you'll touch your finger, wrist and you'll move, you'll not be feeling anything. Crepitus का मतलब क्या? Crepitus का मतलब in auscultation, when there is crepitus, मतलब छोटे छोटे bubbles or bubbles टूटे, टिक 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 टिक, that type of sound. Same sound will come over here. Karr, karr, right? That type of very delicate. But when you touch, you'll be able to feel it. So that is the crepitus worse during flexion, extension, and twisting motion. Right? Flexion, extension, and if you say rotate, so then to he'll chillaega. Right? Because during rotation, it becomes more painful. So this is classically, ये अपने surgery का एक topic हो गया. Right? This is the topic of surgery. It is also called as the crossover syndrome, right? It is also called as the crossover syndrome. And this is called as the Orsman's wrist. This is the differential diagnosis of wrist pain, right? Differential diagnosis of wrist pain between dequervin and intersection syndrome or the Orsman's wrist. I hope this is clear. In one, chamber 1 is involved, and in this case, chamber 2 is involved. Okay? Now comes very rare, right? This is like आपने बहुत अच्छे आंसर दिए और आपको फंसाना है, तो then the examiner would be asking that, okay, tell me what is Ganser's muscle, right? ऐसे कोई गैंगस्टर जैसा नाम, कुछ नहीं है, flexor pollicis longus था, right? Flexor pollicis longus. Flexor pollicis longus का there is one extra head, what is called as the accessory head. So any the accessory head means it is extra. If it is extra, so then it will compress someone. If it compresses median nerve, and in median nerve we mean it's the anterior interosseous nerve, right? Anterior interosseous. So when this nerve is compressed, then this muscle, this accessory head of the flexor pollicis longus is called as the Ganser's muscle, right? Just this is, keep in mind. This is classical. This Ganser's nahi aaye to chalega. Jersey finger compulsorily. Everyone should know very properly, because this is just the reverse of that ball hitting on the Jersey's finger. Now football match, right? When they run, अब वो दौड़ रहा है तो though it is not allowed, but still people do it ना. वो जर्सी से ऐसे पीछे से पकड़ा, right? अब वो थोड़ा ना कहेगा हाँ बेटा पकड़ मुझे आराम से, right? No, he is also running, right? And then when you try, now this is the jersey, when you try to hold, that person is running, right? And it he runs with a force. So now the finger was bent and this time it is straightened. ये उल्टा हुआ, right? Which tendon can break? You are catching, and then forcibly the hands are straightened. So that means the flexors will be involved.
Flexor.
Correct?
Flexor
While वहां पे
digitorum
finger क्या थी?
profunda.
It was hitting this, and the extensors they were getting damaged. So this is just the reverse of it. Jersey finger. This is the traumatic rupture of flexor digitorum profundus. क्यों profundus and not superficialis? Anyone? Why profundus and not superficialis?
Detailed it is.
Superficially
Distal
attaches
phalanx is
to
involved.
Present at the distal phalanx.
Because flexor digitorum profundus is तो going till this point. अब वो थोड़ा ना कि उसको गुंडे की तरह पकड़ेंगे कि चल पूरा हाथ उसकी जर्सी पे डाल के चल बैठ पीछे, राइट? आई बी गोइंग फॉर द गोल. नो, the fingertips are involved and they are snapped back. So that's why flexor digitorum profundus is what would be involved, right? From its point of attachment at the base of the distal phalanx. Perfect, right? FDP tendon is primarily responsible for flexing the distal interphalangeal joint. You know this thing very well now, right? So jersey finger occurs when there is a strong contraction of the flexor digitorum profundus, because you are holding it, right? You are holding that jersey, right? And that is resisted by a force into the distal interphalangeal hyperextension, right? Ye jersey, right? This is the jersey, pakda, and then person is running. So this is called as the forceful hyperextension. And when there is forceful hyperextension, this is torn, right? It is damaged. Resisted by, such as occurs when a player grabs another player's jersey from behind while that player is pulling away, he's going away. Because the FDP is the only tendon, correct? It is the only tendon that flexes the DIP joint. A jersey finger injury with the full rupture of tendon causes loss of active DIP joint, because this is the only tendon. So when the rupture occurs, it goes full-fledged. Two reasons. One, it is done with power. And second, in the heat of that game, right? So the pressure from the outside other person will also be that high. So it will lead to full rupture. The ring finger is the finger most commonly involved. Do remember, ring finger, right? Ring finger is the most commonly involved, with an estimated involvement of 75% of the cases. This is said to be related to the ring digit being ring digit being 5 millimeter more prominent during grip in approximately 90% of the people. Now this is like statistics. When we hold it, so it has been seen that in 90% of the cases, the ring finger, that finger is slightly more protruded and it is giving more power. More power, so more damage. Moving on to the median now. Median now, सबसे easiest to understand. C5 to C8 and T1, right? Because everyone's contribution is there. Because it is the median now is formed by lateral division, which is coming from lateral cord, and the median from the medial cord. So that means तीनों के तीन anterior divisions now they are involved. So that's why C5, C6, C7, C8, T1, everyone is there, right? You got it, right? So C5, C8 and T1. So there are lateral and medial cords, so which are leading to the formation of this median nerve. Initially travels medial side with brachial artery, you know it very well. And in elbow, it goes under bicipital aponeurosis, right? You remember it goes under bicipital aponeurosis, and then it is between two heads of pronator teres. And in forearm, this is between flexor digitorum superficialis and flexor digitorum profundus, and it supplies them also, right? In wrist, now it will be under flexor retinaculum, right? And towards palm of the hand, and then branches and supplies thenar muscles, because median nerve, right? Median nerve, so thenar and the hypothenar, so this median nerve that is supplying the thenar. Thenar mein kaun? All for one. And, right, so this is the abductor thenar. So this is about the pollicis, thumb. So abductor pollicis brevis, flexor pollicis brevis, and the opponent's pollicis, all intrinsic, right? Remember, all intrinsic muscles, right? But plus there was one more, that was the adductor pollicis. But no, this adductor pollicis, that is by the ulnar one, right? So that is separate. So here it is. Median nerve sensory innervation. Median nerve sensory distribution, this is via carpal tunnel, right? Over here, this is the palmar side, and this one is the dorsal side. So see, this is the area. This is the area. This is the area, right? That is supplied by the median nerve. And over here on the dorsal side, that's the area which is supplied by the median nerve. Sensory. The clinical relevance. There are three syndromes which can be associated with it, involving the median nerve and its branches. Very simple, because the point is, where is it involved? At what level it is involved? So first, let's start with the commonest one. This is carpal tunnel syndrome. Those who are sitting into the computers and constantly working, right? Say constant movement of the wrist. That's why many of the mouse pads, they are like those mouse pads. This is the mouse pad, and then there is a wrist support so that your wrist remains at this point, and here is the mouse, right? So that there is no extreme bending, because when you are moving the mouse, see, this is the angle which is made. If there is a support here, so it remains into the normal state, and it affects. It affects, especially if you are into the field of graphic animation, so where you would constantly use the mouse. So this is the carpal tunnel syndrome. Second is anterior interosseous syndrome, and the third is the pronator teres. Rest two are very easy. Carpal tunnel, we need to understand. So carpal tunnel syndrome is a common condition, commonest condition, that causes a tingling sensation, numbness, and pain in the hand and fingers. Right? This is very worse, but it is reversible. So these sensations usually develop gradually and start off being worse during the night. Kyun night? Daytime, then you are moving, right? But at night, when there is micro injury which has occurred, so now starts the inflammation. So next morning when they wake up, kya haath hi nahi chal raha, but kuch pata nahi chal raha. So they tend to affect the thumb, index finger, and the middle finger, right? Now see, index finger, right? Middle finger and the thumb. Which side, right? The radial side, right? Radial side. So this is the thing. This is how it is affected. So other symptoms of carpal tunnel syndrome include pins and needles, paresthesia. That is, paresthesia is when there is change in the sensation, as if someone is pricking it, right? As if there is some pain which is going on. Thumb weakness and dull ache in the hand or arm, right? That is carpal tunnel. When it comes to anterior interosseous syndrome, this is a motor branch. So anterior interosseous nerve syndrome, also called as the AINS, is a pure motor neuropathy, pure motor, right? And as the anterior interosseous nerve contains no sensory fibers, so dull forearm pain is, however, sometimes mentioned, but it is very dull. If anterior interosseous nerve is involved, so that means it is pure motor, right? It is a motor branch. You tell the patient, do okay, right? He won't be able to. Why not? Because in order to do this okay, right, that okay, right, flexion of the interphalangeal joint of thumb and distal interphalangeal joint of the index finger. That is needed, right? This should be bent, this should be bent, this should occur. That is impaired, right? So that's what, when you tell, do this, patient will be doing like this, right? See, he is unable to flex at interphalangeal joint, right? So that's why you tell him, do okay, he'll try to do, and it'll become like this, right? So this is one test, okay. The second test is called as the pinch test. This is the pinch test, which can be all now these are clinical, but very easy, so you can easily understand. Here it is, see, dekho. This is normal, and this is how it will look like, right, when it is abnormal. Anterior interosseous syndrome, this one. Right. What happens in pinch test? If the image is there, so it will take a second. Acha, nahi hai, koi baat nahi. I think it will come. For the pinch test, yeah, all you need to do, paper, right? Take a paper, hold it. Now tell the patient to hold it with the tips, right? With the tips. Now patient is holding. If you pull it, right? If the patient is normal, if you pull it, patient ko bolo pada tight, right? The patient will be able to hold it. Anterior interosseous now, his hand will become like this. This is how it will, right? This is what is called as the pinch test, right? Paper. This is normal, and this is anterior interosseous nerve involvement. The third one is the PT, or the pronator teres syndrome. This is due to position of this muscle that sits over your median nerve, right? Median nerve goes underneath it, right? So the pressure on the nerve can elicit pain while hindering the forearm movement. So it occurs when pronator teres muscle becomes tight or overwork, compressing the median nerve. So again, this is because of the overuse, right? Overuse, right? When you are using some heavy machinery, right? So then it can occur. Or what type? Hammering. So when hammering, right, constant movement, so all those powerful, repeatedly using a screwdriver, they can lead to overuse of the pronator teres because your entire hand is continuously moving. So symptoms include pain and reduced mobility. Carpal tunnel syndromes are often confused with PTS, pronator teres syndrome, right? However, in this case, symptoms worsen with elbow movement. In case of carpal tunnel, right, nothing happened because the problem is here. So nothing would happen if you move the elbow, right? Movement of the elbow, it has got no effect. However, in this case, movement of the elbow will worsen the symptoms. So that's the DD point. DD is differential diagnosis. Carpal tunnel syndrome is a condition which occurs due to pressure on the median nerve, right, as it passes through the carpal tunnel. So how to elicit it? This is called as the Phelan's test. So all of you, if you try to do this, right, Namaste ka ulta, right, and then press, right, then press. If normal pain rahega, right, but if it is like when you start getting the numbness into the hands, that means this is the carpal tunnel. This is a very powerful, very practical test, right? So like this, the way it is shown here, right? Both eyes, and then try to press, right? Both together and then press. So are you getting numbness? So that is the carpal tunnel. And it happens, one of my students was telling that पता नहीं जब भी पढ़ते हैं ना तो लगता है कि and if you try to do that तो you feel हाँ थोड़ी numbness लगी हाँ carpal tunnel तो नहीं है, right? This is normal, especially when you will be learning psychology na, like psychiatry, right? All the conditions when you read तो you'll feel like हाँ यार मुझे भी ऐसा होता है कई बार, especially in schizophrenia, when they say that the whole world is against you, right? You feel कि हाँ बिल्कुल यार मैं इतना अच्छा, मैं इतनी अच्छी, पूरी दुनिया मेरे सामने, right? It happens, it is normal. Okay, so here is the conceptual. This page is like you remember it properly because from this point onwards everything is based on just this small piece of information. So here it is, the three arteries we are, three nerves we are talking about: radial, median, and ulnar, right? Radial, medial, and ulnar. Radial, extensor digitorum, right? Median, purely on the flexor side. Radial to पीछे, extensor side. Median, flexor digitorum superficialis, flexor digitorum profundus, right? Then lumbricals 1 and 2 and the thinner. Makes sense, right? Because median now, सीधी आ रही है, right? So it is all the things. Flexor digitorum superficialis, flexor digitorum profundus, lumbrical 1, lumbrical 2. By the way, we start counting from, this is 1, right? We start counting from lateral to medial. So just for the clarity. And the radial half, right? R half. This is the radial half, right? Radial half. Because flexor digitorum profundus is a big muscle, na? Flexor digitorum profundus is going for 2, 3, 4, 5 digits. So there are two parts, the radial part and the ulnar part. So radial half is by this median now. Okay? On to the ulnar now. Ulnar now, flexor digitorum profundus, baki ka. So ulnar half, right? Also, there would be lumbricals 3 and 4, which will be on that side. Then posterior interossei and the dorsal interossei. They will also be there. And we just said before some time that the thinner muscles, they are by median now, except adductor pollicis, because adductor pollicis is by ulnar, right? I think we just a minute back we talked about it over here. मैं यहीं पे गई था पता it was but we talked about हाँ ठीक है चलो बहुत अच्छा चलो here, right? This is by I'll ठीक. So here it is, right? So this is done. Now the real mechanism of flexion and extension MCP. Full give complete attention for this part. This one figure, right? Here is the DIP, distal interphalangeal joint. So this FDP, flexor digitorum profundus, connects over here. You know that. Over here, flexor digitorum superficialis connects. You know that. And then this is metacarpophalangeal joint. Yes, you also know that. There is extensor digitorum, which is connected over here. This is extensor digitorum. So extensor digitorum is connected at such a point that when it would act, it would do what? It would do the extension of metacarpophalangeal joint. ठीक है ना? Right? This is the thing connected here. So when it pulls, so at metacarpophalangeal joint, it's taking the hand like this. Okay. But story doesn't end here. There is one more muscle involved, and some of the fibers will be landing on that. Right? That makes entire thing interesting. So here, so far, simple. So extensor digitorum only powerful at MCP and not PIP or DIP. Makes sense, right? यहाँ पे तो है ही नहीं ना. It's not there. So if anything happens to them, this PIP and DIP, so they are not affected. Okay, so this is clear. FDS and FDP, they are super powerful. Yes, we know that, as they are so bulky. So that's why the normal position of the hand is like this, right? So extensor digitorum is working over here, but flexor digitorum superficialis and flexor digitorum profundus, they are powerful. So normal hand is always like this. Normal hand is never like this. Normal hand, when you relax your hand, so there will be some tone of the flexor component. So that's how the normal hand is. When you shake hand, so you'll always be, there would be this graceful curve, right? Now comes this new muscle. Now this muscle, right? It is this. It is this. And that is lumbrical. This is the lumbrical. Right? So this lumbrical, this is when it is connected over here. And some of the fibers of MCP, they will be connected to this muscle. Now see, it is taking a turn, right? So this is when that will pull, right? So will it really pull this entire unit down? Correct? Because it will pull. So this is the flexion at metacarpophalangeal joint, these lumbricals, right? But interesting thing is still more. Introtiae, they are pad and dab, right? That is palmar introtiae and the dorsal introtiae. Palmar introtiae are for adductors and dorsal are for abductors. We just see again. So now comes the claw hand. Claw hand का जो concept था, which we skipped at that point, I said we'll be discussing it. Now it has come. So ulnar, right? It is claw hand is with for ulnar nerve injury at rest, at rest, right? So here flexor digitorum profundus is spared because flexor digitorum profundus is supplied at a higher level, right? So which muscles are affected? One, metacarpophalangeal joint, that would be affected. It could be hyperextended, right? Why so? Because prime function of lumbricals 3 and 4, so that is lost. We just said that lumbricals, they are responsible for MCP flexion, right? ऊपर से ऐसे नीचे आके, they're pulling it down at the MCP joint, right? At the MCP joint. So they are pulling down. So this whole assembly, it goes down, right? But that function is lost. So that's why this is hyperextended. Hyperextended. What about PIP and DIP? Support to ED lost, right? Flexor digitorum superficialis and flexor digitorum profundus takes over. Why did we say that ED extensor digitorum is lost? Because extensor digitorum, right? Extensor digitorum was landing over here. But because few fibers, they are landing on to this umbilical also, so that's why it was giving a common pull to PIP, DIP also, right? That's why it was giving a common pull, not DIP, PIP, right? It was giving a common pull to PIP also. So that's why it was keeping the finger straight, because you got it now. Lumbrical is pulling like that, right? Lumbrical is pulling like that, and then that muscle is pulling that also. So it is this, and the hand would really look like. Now, lumbrical is gone. Lumbrical is gone. So then there is no support from ED. Lumbricals, they are gone. So that's why it is hyperextended. Hyperextended, lumbrical is gone. So on that, ED is attached. ED is also, its effect of ED is also gone. So now the super powerful FDS and FDP, they take over. They are over there. So now we know that, see, why the claw hand like this? Because this hyperextension, right? Hyperextension, it is because prime function of lumbricals are lost, right? So they are unable. And this FDS and FDP, flexor digitorum superficialis and flexor digitorum profundus, so they are acting. So now it is what is called as hand. That's how it really looks like, claw hand, right? Claw hand. Okay, we saw that thing over there, right? Saw that thing, that image. You remember this. The next one is, again, spot diagnosis. This is what is called as the Benedict. Yeah. See this, right? Now over here, I just show you something. Okay. Right. So muscles affected. This is the ulnar nerve claw hand. So that's how the claw hand it really looks like. Right. This is the ulnar side. Ulnar. Now we move on to this Pollock sign. Now in Pollock sign, there is inability to extend distal phalanges of ring and little finger. So here, right, you try to extend, once again they will be back, right? Which distal phalanx of ring and little finger, right? Ring and little finger. You try to extend and then they will be, because there is partial loss of wrist flexion because of flexor carpi ulnaris. This is weak ulnar. So here it is. Radial nerve is involved, right? The deep branch, and that is posterior interosseous nerve. So there is selective weakness of extensor digitorum. Extensor digitorum is weak, right? So flexors will take over. So even if you try to extend, once again, they will become like this because extensor digitorum is not functioning properly. Why extensor digitorum not functioning? Because posterior interosseous nerve palsy. Posterior interosseous nerve, which is deep branch of radial nerve. This is Wartenberg sign. This is loss of adduction of fifth digit. This is the fifth digit, right? So here, this side, so it is ulnar side, right? Last third palmar introssea is weak. So he said na, that this introssea is weak. So then that extensor digitorum, digiti minimi, that takes over. So it goes like this. So finger catching while placing the affected hand in pocket. So finger catching is that as forcefully you are inserting your hand into your pocket and ye finger bahar reh gayi. And then it gets extended and it leads to that damage, right? This is what is called as the finger catching. Pura haath andar jane ki jagah ek finger bahar reh gayi and then it is bent. Right? Like this. This is once again that Froment sign, if you remember, we talked about, right? That pinching, right? Examiner is pulling. This is normal. This is normal. And when it becomes slide, right? This is normal. And this FPL takes over, right? Sensory loss, right? Sensory loss. Ulnar side and the palmar aspect, dorsal aspect. Now this is ape hand. Ape hand is median nerve injury. Easiest thing. Thenar muscles are involved. Abductor pollicis brevis, flexor pollicis brevis, and the opponent's pollicis. Right? These are thenar. Thenar are gone. Thenars are not working. Thenar are not working. So that's why the entire thing, like that 90-degree rotation, that is the abductor pollicis brevis, which is keeping it at 90 degree. Right? Flexor pollicis brevis and the function of this opponents, all those things, they are lost. But adductor pollicis, the fourth muscle, that is working because it is supplied by ulnar. So that's why thumb will become parallel. So now the hand is like a monkey, right? So this is what is called as the ape hand. 90-degree rotation, that is lost. So this is like thenars are gone. This adductor pollicis, right? Adductor pollicis, it takes over and thumb goes into dorsal plane and that leads to ape hand, right? Typically, these are lost. So here, this is how it looks like, right? Just like this. Over here, high median nerve injury. When flexing fingers, right? High median nerve injury, injury at a higher level. So this is called as hand of benediction, God's hand, right? Ashirwad dete hue. Most common injury is supracondylar fracture of the humerus. That means we are talking about above the elbow, right? Your humerus is damaged over here in your patient. So anterior interosseous nerve that is affected. So here flexor digitorum profundus, radial half, that is damaged. Flexor digitorum profundus damage. So obviously no flexion. So extensors, they will say, chalo sida, right? They will keep the hand straight. So loss of flexion at PIP and DIP of index and middle finger. Index and middle finger. Because we are talking about the median side, right? Median side. So here it happens that there is loss of flexion at PIP and DIP of index and middle finger. Because extensors, they take over, right? So this is how it will look like, right? It will, as you say, this is like an active sign. You tell to flex your fingers, right? But he won't be able to. It will be going like this only. This is called as active finger. Active finger means if you tell for certain movement and it will happen this way, right? So here it is, right? And you say bend. So then these two fingers, they won't be able to, because extensors will take over. But this will bend. So the hand will look like this, right? So flexion at the thumb is also prevented as both the longus and brevis muscles, they are paralyzed. Active occurs only or appears only when patient tries to flex. And when it was ulnar nerve, the same posture occurs with the hand at rest, right? This is due to paralysis of medial umbilicals. So in that case, it is called as the ulnar claw, right? Ulnar claw. This is when both are involved, right? In some injury, when full claw hand, the thenar and hypothenar flattening, muscle wasting, and thumb goes in adduction and flexion. So this thumb goes in adduction and flexion. The whole hand becomes like this, all the joints. So this is median now, ulnar, and all these muscles. So flexor digitorum superficialis, flexor digitorum profundus, radial half, ulnar half, entirely involved, all umbilicals involved, all thenar involved, right? So that is what leads to this muscle wasting. Radial neuropathy, right? Muscles impacted, extensor in the posterior side, radial, and forearm extensors at the wrist and MCP, right? Because of the position. Now you know this part. Motor symptoms, extensor gone to wrist drop, right? And kahan pe? Humeral fracture, mid shaft. That was the point where it can be damaged. Blood vessel कौन सी इसके साथ? Profunda brachii, or also called as deep, right? Proximal lesion location in the axilla, right? In the axilla also it can be damaged. If you remember improper use of crutches and that Saturday night palsy, right? The compression, and it leads to this. Muscles, triceps brachii, that is more commonly affected. And this is like a wrist drop. This is piano key. This indicates subluxation of the ulnar head. Ulnar head is like this. Ulnar head is like this. Sometimes it slips out of joint. Right? Sometimes it slips out of. So that is what is called a subluxation. And here, so when the hand is like this, you will find that this head, normally when you put the hand, it is not that prominent, but it will look very prominent. But when you press it, it will go down, and as soon as you release it, it will come up. So that's why we feel this is like a piano key, right? So it springs back to normal, and this is how it looks like. So you press, right, it comes back. Press, it comes back, right? But it is painful. But this takes us to the last part, imaging evaluation of upper limb, radiograph, X-ray, so wrist, PA, lateral, oblique, PA with ulnar deviation, all those sorts of angles. Concept is one simple concept. The area of interest that should be near the plate so that it is less magnified and it is in sharp focus. So that's why The normal PA view, but the lateral, oblique, spatial views, they are taken for the diagnosis. Wrist, hand, same way. Spatial views, they are for scaphoid, carpal tunnel, stress view. I mean, some of the X-rays, they are taken like this, and then the X-ray plate is put it like this, so that you see this area, right? Then the arthrography. When the arthrography comes, it means when you can watch it. So ligamentous or cartilage abnormalities, you can do CT scan, right? You can do MRI, it is seen clearly. But still, if you want to have a visual inspection, so then you put the arthroscope inside and just have a look at it. Major risk compartments, radiocarpal, distal radiocarpal, midcarpal. And for that, for anesthesia, local anesthesia, 1% lidocaine or liglocaine, that is what is given. It is a water-soluble thing. Arthrography, yeah, we talked about it. This is radionuclide bone imaging. Here, the keyword is, these are the two keywords, extremely sensitive but low specificity. Sensitive means whether thing is there or not, it will pick up very clearly. Whether it is normal or abnormal. If it is abnormal, so it will definitely pick it up. Yes, that is what is called as the sensitivity. But specificity means what it is, it will say no. For that, you do other investigation. I can say that something is wrong, but what is wrong? No. For that, it is low, right? So this is the important thing, sensitivity. What is used is technetium 99M, that is coupled with phosphate compounds. This is prepared and it is injected into the body. And then it is tested that where exactly it is getting collected. Right? So phase 1, phase 2, phase 3. Phase 1 is the angiography. When the blood flow is there, right? When as you inject, you just see the blood flow. Second, blood pool. So that blood, it goes, because now it is injected with technetium 99. So you'll be able to see it, right? So soft tissue status, you'll be able to see it. And phase 3, late 2-3 hours, cartilage and bone information, where you'll start getting that in which bones it is getting deposited, why it is not moving. So there must be something wrong. And this is one of the very fine thing for diagnosis of AVN or the avascular necrosis, right? Avascular necrosis. When the nutrient artery of that particular area of the bone is damaged, and then that bone becomes necrosed, sarna shuru ho jata hai. Commonest thing which is seen in the hip region, right? Avascular necrosis. Nowadays, CT scan is done more commonly because you can also do the staging. If it is stage 1, stage 2, so then you can go for conservative therapy. But if it is stage 3 and if stage 4, so then there is no other option but to go for surgery. Yes, we saw this. CT scan, sectional imaging with or without contrast media, right? Iodine medias, they are used. But occult fracture of wrist bones, those very small fractures, sometimes they are not seen on plain radiograph. So that can be seen. And bone graft incorporation. So if you have put a bone graft, want to see the status of this. Or osseous fusion, there is fracture and now it is getting repaired. You just figure out what level it has reached. MRI, magnetic resonance imaging. In this, there is no use of radiographs, no use of radiation. So this is direct vision of bone, cartilage, and soft tissue. The biggest advantage is that you'll be able to see the fluidity of the structure, right? As we discussed previously also, so you'll be able to see the functionality and you'll be able to see that how much water it is. So direct vision of bone, cartilage, soft tissue, occult tendon ruptures, occult fractures, T1 and T2 weighted images. And this is 3D generation, GRE sequence, what is called as the gradient echo sequencing. So you can combine multiple images and then you can create a 3D structure which you can rotate and you can figure out that where the lesion is. Because it is all digital. Then finally, ultrasound, USG, very powerful, right? For this, special probes are there, those small probes. They are not like abdomen big probes, small probes. And with that, you can really figure out the quality of the tissue. Functional anatomical, right? So many machines. It looks like, simply, it looks like this. And finally, wrist arthroscopy, ligamentous injury, or if there is some loose body, anything is inside, or synovial biopsy, and you want to take the fluid out and check. And if there are so many formation of all those salts, so you want to debride, that is, you want to remove it, cleaning it, and accurate in location interosseous ligament injuries. If there is any injury, so that can also be visualized directly. All these are for the direct visualization. So this was the hand. And now you know that there is so much. And still we haven't seen the examples of CT scan, MRI, etc. Right? So even though we feel like a hand to bus upper limb is not important, so many things and even 10 times more things they can occur. We have not yet talked about in-harm. We have not talked about pulse pace. We have not talked about transmission of this infection, how it goes into blood streams, how can even it affect other areas. What happens when the secondaries, they come over here and they start lodging. All those things we have not yet touched. We have not touched even the embryological abnormalities. Right? Cleidocranial dysostosis, we just talked once, and even apart from it, there are so many. So that is the upper limb. Right? But you must have got the idea that how the whole thing is to be studied. Now you'll be following the same pattern even for the lower limb. Lower limb. Everything. अब तक जो पढ़ा एग्जाम के लिए तो we are planning for everything. Okay, so thank you so much. And take care and wish you a very happy, nice weekend.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir. Thank you, sir.
Thank you. Bye-bye.